Welcome everyone to our last ACT-CTU clinical trial rounds before we pause for the summer. Today, we are very fortunate to have our speaker, Dr. David Leaf from the University of Harvard Medical School, talk to us about target trial emulation. So this is a very new topic I know nothing about, and so I'm very excited to hear this. To present our speaker, we have Dr. Patrick Lawler, and I'll pass.
Great. Thanks so much. Thank you very much, Amanda. And thanks very much to everybody for coming. Major thanks to David for being here. I know many people joining online and many people likely to watch later. So this is a phenomenal resource to be able to hear from Dr. Leaf about his work. So Dr. Leaf is an associate professor of medicine at Harvard Medical School, critical care nephrologist at Brigham and Women's Hospital. He did medical school at NYU, was Phi Beta Kappa, if I'm not mistaken, then Columbia for residency, Brigham and Women's after that in a nephrology ICU track. And now he leads a very dynamic and impactful program of translational science in that space now. At least three R01s, multiple, incredibly impactful practice influencing publications during the COVID-19 pandemic and beyond. And he and I have had the privilege of working together on a handful of clinical trials in COVID-19 and now beyond. And really, I think what's been so much fun for me is just sort of seeing the range of science that David is able to represent and so sort of nimbly navigate and weave together. I would say that there are really very few people as translational as he is. And so I think it's really very, very exciting to have him here. And so without further ado, to everybody here, and online, of course, which is a lot of people, I'll pass you the mic.
Thank you so much, Patrick. Thanks for the invitation. It's a real honor to be here. Montreal is such a beautiful city. I was talking with Patrick earlier. I mean, I really enjoyed going for runs and walks and eating great food, and people are so friendly here. It's really terrific. I look forward to coming back with my wife and kids and having some more time to explore. So I'm excited to tell you a little bit about target trial emulation. I understand a lot of the people in the audience are clinical trialists. I consider myself a clinical trialist. Pretty much all of my grant funding comes from doing clinical trials. So I'm not here to convince you that clinical trials are not important. But there are some questions that cannot be answered by clinical trials. And when it comes to observational research, I hope to convince you that target trial emulation, or TTE, I guess I should be careful with that abbreviation with the cardiologists. But TTE is a powerful tool for observational research. Excuse me. Oh, and so I guess feel free to ask questions throughout in the chat, or you can wait till the end if you prefer as well. So here are my disclosures. None of them are relevant to the talk. So this is just an overview about me and my research. So most of my research is clinical and translational, as Patrick said, and it's mostly focused on AKI. Although, as you will hear, I love internal medicine, and when I get interested in a topic, even if it has nothing to do with the kidneys, and even if I don't have funding for it, I will pursue it. And often the unfunded stuff is more fun than the funded stuff. So within AKI, I'm interested in clinical trials, biomarkers, translational immunology. Actually, Patrick and I are collaborating on some studies using peripheral blood mononuclear cells, doing RNA sequencing. I do a lot of work on onconephrology, the intersection between oncology and nephrology. And a lot of my interest is in the role of iron and hemolysis. Actually, the reason I'm up here in Montreal now is because there's a big iron conference taking place. And so just taking a step back, since this is a big food city, I thought I'd give a little analogy. If we think about the two flavors of research, we have RCTs and we have observational studies. Now, RCTs are, of course, the gold standard for efficacy. But as we know, RCTs are expensive and slow. And because they're expensive and slow, they're often underpowered. They often rely on surrogate endpoints, and they often have limited generalizability due to very strict inclusion and exclusion. But they are the ice cream sundae of studies, if you will. Now, observational studies, on the other hand, are subject to residual confounding, but they can be helpful in identifying risk factors and prognostication. They can inform the design of future RCTs, and perhaps most importantly, they can inform clinical decision-making when data from RCTs are unavailable, which is the case in the vast majority of things that we do when we take care of patients. We don't have RCTs for the vast majority of decisions we make. Now, sometimes you want the ice cream sundae, but sometimes a vanilla milkshake is good enough. So how do we make, so the question is not, is there a role for observational studies? I think the question is the most of observational studies. And I would argue that the answer is with target trial emulation. Target trial emulation is a causal inference methodology that incorporates features of RCT design to minimize in the analysis of observational data. The first step is to imagine what would your ideal RCT look like? If you had infinite resources, what would it look like? What would the inclusion exclusion criteria be? What would the outcomes be, etc. Step two is to analyze your observational data in a way that emulates that target trial as closely as possible. And arguably, step two actually starts even before the analysis. It starts with the data collection and trying to collect as detailed data as possible. Even more important for an observational study than for an RCT, arguably, because you are going to have to adjust for all of those variables in order to mimic randomization. And I hope you don't mind. I have a few quotations I'm just going to read because he says it better than I possibly could. So Miguel Hernan is arguably the grandfather of target trial emulation. He's a biostatistician at the Harvard School of Public Health, and he basically invented TTE. And you know, he's written books on causal inference. And I had the great privilege of learning directly from Miguel during the pandemic. And this was actually one of our responses to one of our papers that we were responding to reviewers. We actually used this exact quotation. Traditional, and what we were responding to was a reviewer said, "Why target trial emulation? How is this? How is this different from just a regular observational study?" And so what Miguel said was, traditional observational studies that do not try to explicitly emulate a target trial have resulted in erroneous findings, such as the conclusion that postmenopausal hormone therapy was associated with a 30% lower risk of coronary artery disease, or that statin therapy was associated with a 44% lower risk of death for patients. These findings become null, as they should be, when the observational analysis is designed to explicitly emulate the corresponding target trial. Miguel has written editorials about target trial emulation in the New England Journal, and I wrote one in JAMA, and just a few additional quotations. Causal inference involves specifying a causal question and answering it. The question is articulated in the form of the target trial protocol, which incorporates eligibility criteria, treatment assignment, start and end of follow-up, and a data analysis plan. For researchers using observational data, a useful way to specify a question is to design the target trial that and then emulate the protocol as closely as possible. Emulating randomization generally requires data, I would argue detailed data, on prognostic factors that are associated with treatment decisions. If all such confounders were correctly measured, there would be no difference between a randomized trial and an observational analysis emulating it. And I underlined if, because that's a big ask. And that's why it's so important to have really detailed, is that it just have a bunch of, you know, comorbidities based on ICD code. Do you guys use ICD codes here? You know, I'm not in, you really need the granular data. You actually do this in actuality. 4 key principles of TTE that I've described, and arguably the most important. Use a similar element for the corresponding RCT. So, surprised how often people try to adjust away, of course, adjust or a group of patients that clearly would not be eligible for the corresponding target, adjust away, exclude that patient altogether. The second principle is to use the same time zero for both groups to avoid immortal time bias. Immortal time bias is not something we need to worry about in RCTs because patients are generally randomized to one treatment or another at the same point in time. But in an observational study, you can get into trouble with immortal time bias if there is a lag between your time zero and your start of treatment. A ridiculous example of immortal time bias would be if ICU patients were offered tea and crumpets on ICU day 3. And actually, maybe that's a good analogy. Do you guys have tea and crumpets here? Subsequent analysis would likely find that tea and crumpet recipients have lower mortality than tea and crumpet non-recipients. Well, of course, because they had to live to day 3 in the first place. I mean, this is an obvious example, but there are other examples that are less obvious. Imagine an RCT where after patients are discharged from the hospital, you randomize them to an SGLT2 inhibitor versus placebo. Well, they have to go to the pharmacy and fill the prescription in the first place. And if you die before that, then you never had the opportunity. The third principle is probably something that will be the most familiar, but is also probably the hardest thing to do. Adjust for detailed baseline confounders to emulate treatment assignment. It doesn't really matter how you adjust. You can use regression, you can use matching, you can use inverse probability weighting. The key is having the detailed data in the first place, a point that I keep emphasizing because it's so important. And then the last principle is analysis by intention to treat. The idea of comparing the effect of being assigned to treatment A versus B at baseline, regardless of potential crossover later on. Everyone here who does RCTs knows that intention to treat is the gold standard for analyzing an RCT. When it comes to observational data, we don't usually think about intention to treat, but it makes sense to do so. And it's actually easier if you do that as well, because then you don't have to deal with time varying confounding. You analyze the patients in the initial group they were assigned, and if they cross over, they still have to stay in the same group that they were originally assigned to. Now, target trial emulation can be applied to virtually any area of medicine, and we've done that. And so I'm glad that the audience is multidisciplinary, because hopefully there'll be a little bit of something for everyone. The three of the major areas that I've used target trial emulation on are COVID-19, onconephrology, and interestingly, babesiosis, which is not a major problem in Canada, but it's still, I think, an interesting thing to talk about. So during the pandemic, my mentee, Shruti Gupta, superstar in my division, and I led a multi-center observational study on COVID-19, which I'll talk about, and we did 4 TTEs among many other papers. And I'll just go through a couple of them just to give you an example of how to do TTE in practice. So just in terms of quick background, particularly early on in the COVID-19 pandemic, and particularly in the setting of critical illness, initial studies were limited. They were limited by small sample size. Right? The first paper in the New England Journal had 20 patients. Now, they were the first 20 patients in the US with COVID-19. I get it, but still. Poor data granularity, short follow-up, and limited generalizability. Most of the studies early on, and even later on, were single center. Therefore, the unmet need was the creation of a large, detailed, and nationally representative database of critically ill patients with COVID-19 in the US. And such a database would have detailed data on all of these covariates that you see on the left. So we launched Stop COVID, study of the treatment and outcomes in critically ill patients with COVID-19. And actually, the STOP works well. And I've been using that I've been using that acronym for other things. Study of the treatment and outcomes in patients is, STOP. So I'm stopping COVID. I'm stopping all, onconephrology stuff. So Stop COVID is a study we did with no funding, where we enrolled 5,000 patients. I say enrolled. I mean, it was, not a single patient signed a consent form. This was observational, but over 5,000 patients from 68 medical centers across the U.S. We do not have a standardized EHR in the U.S., which is crazy, but it is what it is. 68 medical centers, over 400 collaborators, and these collaborators range from medical students all the way up to division chiefs. And everyone was a co-author on every paper. That's how we were able to do it without funding. Over 800 data elements per patient, published over 25 papers, but the most impactful of the papers were the TTEs. Those were the ones that I think had the potential to really change clinical practice. And these are 4 of the TTEs we did: tocilizumab, anticoagulation, ECMO, and prone ventilation. Patrick and I were baking out in the sun right before this, so I'm sweating so much. So we collected our data using REDCap. Do you guys use REDCap here? Awesome. So I don't have to tell you how amazing REDCap is. And I've been using REDCap for more than 10 years, but every day I feel like I learn more and more new features. So it's HIPAA compliant, it's user friendly. There's a lot of advanced features like branching logic, automated data validation, which is really important when you're doing multi-center studies, and you might have a research coordinator somewhere that doesn't really know much about the topic, and there may be keystroke errors, and you want to catch as many of those errors in real time as possible. All data were extracted by manual chart review, and it took 1 to 2 hours per patient. I actually, just the lab data alone, we collected 20 labs on a daily basis for 14 days. So if you 20 times 14 is 280, that's 280 questions just for the labs. And if those were stacked one on top of each other, you could imagine just scrolling down the page would take forever. So I actually enlisted the help from my brother-in-law who works for Google, and he was able to write some code. There's an add-in package for REDCap where you can make these pretty matrices, which, as you can see, makes entering the lab data a lot easier. So the three primary goals of Stop COVID were to study the clinical features and outcomes of these patients, to assess interhospital variation in treatment and outcomes, which is super interesting. But I'm not going to, in the interest of time, I'm not going to talk about these first two. But if there's questions about it, I have extra slides at the end. Most importantly, to perform causal inference analyses of the effects of treatments on outcomes using TTE. So just to tell you a little bit about the initial timeline. So we started this in mid-March of 2020. And in that initial month, so in 1 month, we built the REDCap database with 800 plus questions. We established collaborations with 65 medical centers. Eventually, it would be 68. We executed 65 separate IRB approvals and 65 separate data use agreements. And we collected data on the initial 2,000 patients. Eventually, this would be 5,000. We then gave ourselves 3 days to clean and validate the database, which at that point had roughly 2 million data points. We gave ourselves 3 additional days to analyze the data, make all figures and tables, write the initial paper, including 20 plus supplemental figures and tables, and collated the comments from over 200 co-authors. And on April 21st, we submitted our first paper to the New England Journal of Medicine. I'll just tell you a little bit about the review process, because it was interesting, during the pandemic. So it was sent out for ultra rapid peer review to 3 reviewers, and the reviews were completed in less than 48 hours. It was then sent to review, which is typically the last step before they accept a paper. There were no major concerns identified. It was discussed again at full committee, and then it was rejected. And the reason it was rejected, they said primarily because at this point in the pandemic, this is at this point it was April, at this point it was May of 2020. We think the pandemic is pretty much over, or is coming to a close, and we really just want clinical trials at this point. We're past the epi point in the pandemic. We appealed with a detailed point by point rebuttal letter, which I've actually never done before. Discussed again at full committee and rejected again. So anyway, we didn't get it in there, but we tried really hard, and we're still happy with it. Ended up getting the first paper got into JAMA IM. I wanted to talk a little bit about TTE in Stop COVID. These are the 4 interventions that we looked at: tocilizumab, therapeutic anticoagulation, ECMO, and prone position ventilation. I'm going to spend a little more time on tocilizumab, or TOSI, just so you get more of a flavor of how to do this type of analysis. And then I'll go through therapeutic anticoagulation very, very briefly, and it probably won't have time to talk about the other 2, because I don't want to spend the whole time on COVID stuff. So TOSI is a recombinant humanized monoclonal antibody against the IL-6 receptor. It's used to treat vasculitis and cytokine release syndrome, for example, in patients who have undergone CAR T-cell therapy. The dose is typically 8 mg per kg IV once. The onset is within 4 hours. Half-life is roughly 2 weeks, and it costs about $5,000. Probably not something that's terribly relevant, I guess, here with universal health care, but something that unfortunately we think about it in the U.S. Now, why examine TOSI in COVID-19? Well, early on, we knew that hyperinflammation was an important driver of morbidity and mortality in COVID. We knew this from things like the recovery trial with dexamethasone. There were reports that higher circulating IL-6 was linked with worse outcomes. And there were also early anecdotal reports of improved outcomes in patients with COVID-19 who received TOSI. So we tried to answer the question, does early treatment with TOSI improve survival in critically ill patients with COVID? And we focused on early treatment because we hypothesized that if it's going to work, it's going to work. Oh, thanks so much. Patrick and I were baking in the sun for like an hour right before this. Something I'll never do again. Before I talk, thank you. we hypothesize that if it's going to work, it's going to work early on, prior to the onset of irreversible organ injury. This paper we also published in JAMA IM in October of 2020. And basically, here's the flow chart. So we started, at this point, we had almost 5,000 patients in our cohort. And just like you would have a flow chart in an RCT, we had our exclusion criteria that mimicked the exclusions for an RCT. In fact, we looked at the clinicaltrials.gov ongoing trials, we looked at their inclusion exclusion criteria. For example, if you have elevated AST or ALT, that's a contraindication to getting TOSI. So that was an exclusion, just as an example. Or if you had already received TOSI, that was before coming to the ICU. Admission to the ICU was our time zero. And basically, I can't say we randomized the patient, but we categorized the patients according to whether or not they received TOSI early on. And we defined early on as within the first admission. And we had 433 patients who did receive it and 3,491 who did not receive it in the first 2 days. Patients who received it beyond the first 2 days were still included in the group on the right. Again, intention to treat principle. These are some of the baseline characteristics. The arrows represent some of the imbalances between groups. As you can see, the patients who received TOSI tended to be younger. They had more comorbidities, and they were also sicker. So I'm sorry, they had fewer comorbidities. They had less hypertension, less coronary artery disease, but they were sicker. So they were more likely to have hypoxemia based on the P to F ratio, as you can see here, ventilated and P to F ratio less than 200. And they were also more likely to be inflamed. And we defined inflammation using a combination of biomarkers like CRP and ferritin. So that's not good, right? We don't want the groups to be imbalanced. So we used a technique known as inverse probability weighting to adjust for confounding. Inverse probability weighting is a propensity-based method that assigns a certain amount of weight to each patient depending on their likelihood of receiving or not receiving the intervention. And the covariates on the left are 28 pre-specified variables that we determined were potentially related to a clinician's decision to prescribe TOSI and also potentially related to the outcome of death. In other words, these are potential confounders. On the x-axis is the absolute standardized difference between groups. If you think, absolute standardized difference is kind of like Cohen's effect size. If you think back to college level biostatistics, you may have learned about the Cohen's effect size, where 0.2 is considered small, 0.5 is considered moderate, 0.8 is considered large. So people often use a cutoff of 0.2 or sometimes 0.1 to define what's important, to define a clinically relevant difference between groups. The black circles represent the absolute standardized difference prior to applying the weighting, and the red triangles represent after the weighting. And as you can see, prior to the weighting, there are some covariates that are to the right of 0.2. They have higher ASDs than 0.2. They're not well balanced. But after applying the weighting, you can see everything is to the left of 0.2. So in other words, the inverse probability weighting worked to create a pseudo population of patients that appeared similar at baseline. And what we found was that TOSI treated patients had improved survival. We can see that with the Kaplan-Meier curve on the left. You can also see it with the adjusted Cox model shown here in the primary analysis, an adjusted hazard ratio of 0.71, indicating a roughly 30% lower risk of death in those who received TOSI. And interestingly, I don't know, sorry, but the triangle, the rectangle cut it off a little bit. But one of the subgroups that was interesting was days from symptom onset to ICU admission. So patients who received TOSI, patients who presented to the ICU within 3 days of symptom onset, those patients seem to particularly benefit from TOSI. You can see the adjusted hazard ratio is 0.41 in those patients. And sorry, it's a little cut off below, but you can see the p-value for interaction is significant. So we'll come back to this in a second. These are the sort of early, the people who present early on seem to benefit more. Now, how do these results compare with subsequent RCTs of TOSI in COVID? So the very same day that our RCT, the very same day that our observational study was published in JAMA IM, the same journal on the same day published 2 negative RCTs, and one day afterwards, the New England Journal published a 3rd negative RCT. So imagine within 24 hours of your publishing your paper, there's 3 negative RCTs. So I start getting emails from reporters from places like CNN, USA Today, Washington Post, and which is cool, because I don't usually, I don't usually have that, especially, as an AKI researcher, it's not usually all that interesting to the general public. And they were asking me, so how do you reconcile this? Your observational study, you've got your findings and you've got the RCT. And I said, yeah, the RCTs are wrong. And they said, okay, so you want us to believe that 3 RCTs are wrong, but your observational study is not be. And I said, because the RCTs are vastly underpowered. The RCTs had 100 patients each, or in the case of the New England Journal paper, a little over 200 patients, vastly underpowered. They had to be negative. Um, and and so there were actually conflicting things that were published in the lay press about, in terms of whether TOSI is beneficial or not, depending on if they believed my results or the RCT. And I actually published a letter in the New England Journal about the RCT that they published, which was actually from investigators from my own institution, basically criticizing the study. And I basically said that the trial by Stone et al. Was also severely underpowered. In the placebo group, the percentage of patients with a primary outcome event was 12.5%, far lower than the anticipated 30%. A post hoc power calculation reveals that with this event rate and with the number of patients they enrolled, which was 243, it would have been nearly impossible for the trial to have shown a significant effect. The risk of the primary outcome would have had to have been more than 80% lower with TOSI than with placebo. And nothing in medicine reduces anything by 80%. So it would be a negative. And you could see graphically, our study versus the RCT in terms of the outcomes. We had 35%. 35% of our patients were dead within 28 days compared to 4.9% in the RCT. So event rate and also sample size. So you can imagine I breathed a sigh of relief when the REMAP CAP trial, led in large part by Patrick, published a few months later the definitive RCT in this population of critically ill patients. So REMAP CAP is an international adaptive platform randomized open trial. They did many of the pivotal trials during the pandemic, and they did a trial of TOSI where they compared TOSI versus control. It's control, not placebo, but because it is open label. But these are ICU patients. I'm not sure there's going to be all that much of a placebo effect in someone who's intubated and sedated. Where the primary outcome is death. So TOSI versus control, hospital mortality was 28% versus 36%, which an 8% absolute risk, 8% absolute reduction in hospital mortality, a number needed to treat to save 1 life of 13. A few months later, the UK group, the recovery platform, published an even larger RCT of TOSI versus control. This was a multi-center randomized, again, open label trial involving 177 sites in the UK, comparing TOSI versus control in over 4,000 patients, looking at 28-day mortality, 31% versus 35%. You may say that's not a game changer, but highly statistically significant. And what's interesting, even if you look at the subgroup analyses from this trial, with patients, they could do fairly robust subgroup analyses. Look at the group that stood out, days from symptom onset. So they used a slightly different cutoff than we did, but still, it was the patients who presented within less than 7 days that seemed to benefit particularly more. So even at the subgroup level, our analysis was by a subgroup. And if you're still not, oh, yeah, that's, yeah. So I'll repeat the question for the audience. So the question was, in the RCT by Stone et al., did they have sick patients basically? Oh,
They're very inflammatory, so they're more likely to respond to.
yes. So the RCT by Stone et al. Was only 243 patients, so not, and certainly they couldn't do subgroup analyses on, but they, as you can see, only 4% of the patients in their RCT were admitted to the ICU at the time of enrollment. So this, completely different patient population. A much less sick population. Yeah. Okay. And then if you're still not convinced, a couple months later, JAMA published a meta-analysis of all RCTs on TOSI for COVID-19, over 10,000 patients from 27 RCTs, and they found a benefit for 28-day mortality with an odds ratio of 0.83. Okay, so that's TOSI. I'll just mention therapeutic anticoagulation briefly. So why examine it in COVID-19? Well, hypercoagulability was recognized early on as a key mechanism of acute organ injury and death in COVID-19 from autopsy series and other data. But there was limited data on the efficacy of therapeutic anticoagulation. So we published this in Annals of Internal Medicine in January of 2021. We did a TTE comparing the effect of early initiation of therapeutic anticoagulation versus no early initiation of therapeutic anticoagulation on survival. And again, we defined early as first 2 days of ICU admission. We excluded patients if they were receiving therapeutic anticoagulation before hospital admission, or if they had a confirmed or suspected venous thromboembolic event, ECMO, major bleeding, or thrombocytopenia. In other words, if they would have been excluded from the corresponding RCT. Oops. And the bottom line, I'll just skip to the results. We found no effect on survival. And this was across every subgroup we could look at. We could not find any benefit in any subgroup, and we looked really hard. Across the board, it was negative. Now, how does this compare to subsequent results from RCTs? So again, Patrick, Remap Cap, along with other groups, published the definitive trial a few months later in the New England Journal. Over 1,000 critically ill patients assigned to therapeutic anticoagulation versus usual care. The primary outcome was organ support-free days, and the study was actually stopped early for futility because it was so clear that there was no effect. And you can see that here, similar percentage of organ support-free days between groups, and actually, not surprisingly, there was a higher risk of major bleeding in the therapeutic anticoagulation group. Now, I don't want to spend the whole talk on COVID, so I'm not going to do ECMO and prone position ventilation, but if there are questions on that, I'm happy to talk about that at the end. I'll just conclude this part of the talk by saying about a year after we started this consortium, there was an article in USA Today which had a nice quotation, which I'll read. Without funding, Stop COVID relied on more than 400 research coordinators, nurses, residents, medical students, and physicians across a range of specialties, all volunteers, to review the charts of more than 5,000 patients and hand enter 800 data points on each. Many times, caregivers would finish a grueling shift in the intensive care unit, then come home and spend unpaid hours entering data, which is true, and it's really heartwarming that people put so much time and effort into this, and I think it's a feel-good story about what can be accomplished with a grassroots effort, which we then replicated with subsequent studies, which I'll talk about. These are some of the publications that resulted from Stop COVID, or these are some of the journals that we published in. Okay, so onconephrology is another big area of interest to me. Are there any oncologists in the room or on the Zoom? I guess we don't know. Well, anyway, I work at Brigham and Women's, which is affiliated with Dana-Farber, so we have a lot of protoxicity. So we have leveraged that data and to try questions. So I won't talk about all 4 of these, but I'll just talk about a quick background on high-dose methotrexate and glucarpidase. So high-dose methotrexate is an old chemotherapy medication. It was one of the first ones developed, I want to say in the 1950s, 1960s, and it remains a corner and leukemia involving the central nervous system because it's one of the only chemotherapies that can penetrate the blood-brain. Among the most common and consequential, because we all know the kidneys are the most rapidly cleave, actually isolated from a bacteria. I'm blanking on the name from Pseudomonas, and then it was recombinantly approved in 2011. So it works very well biochemically, and that was shown in this paper in JCO in 2010. On the graph on the right, no methotrexate levels is on the log decreases. And they said it, which I highlighted, plasma methotrexate concentrations decreased within 15 minutes of glucarpidase by 98.7%. Great. But what was their conclusion, though? I completely disagree with. Their conclusion was, therefore, in patients who develop high-dose methotrexate-induced renal dysfunction. What? They didn't have any control patients. Every patient in this study got glucarpidase. So how in the world could they? Right? It's effective biochemically, but this doesn't tell us anything about whether it's effective clinically. So despite its potent biochemical effects, no study has just even get rid of the word rigorously. No study has examined whether it improves clinical outcomes in patients with high-dose methotrexate toxicity. As a result of this knowledge gap, there is considerable inter-hospital variation in the use of glucarpidase because it's very expensive. It's about $50,000 a dose. Some people believe in it, some people don't. So we have a nice natural experiment where there's some hospitals use it, some hospitals don't. Even within the same hospital, there's variation between providers. And there are therefore conflicting guidelines on who should be treated. We just published this paper in Blood a few weeks ago, where we looked at this. So let me go through this. So we conducted a multi-center cohort study of 708 adults with methotrexate-associated AKI from 28 major cancer centers across the United States, and those centers are shown here. Data collection, again, manual review, REDCap, over 400 data elements per patient. So similar to, we learned from Stop COVID. As time went on, we got better and better at making these REDCap databases. The primary exposure was receipt versus no receipt of glucarpidase within 96 hours of methotrexate initiation. The primary outcome was kidney recovery at discharge, at hospital discharge. And the statistical analysis used a TTE framework with multivariable adjustment for demographics, comorbidities, etc. We included adults who received high-dose methotrexate who developed AKI. And we excluded patients if they had end-stage kidney disease or if they were moribund at the time. The primary analysis was, as I mentioned, glucarpidase receipt versus no receipt in the first 4 days, multivariable logistic regression, and we used what's known as a sequential TTE design, which I'll talk about. And we had a number of sensitivity analyses as well. These are all the covariates that we adjusted for in the multivariable models. I won't read all of these to you. The most important, actually, are the ones I highlighted on the right. So the 24-hour plasma methotrexate levels and the maximum fold change in serum creatinine. In other words, the severity of the AKI. Those were the two probably most important confounders, which I'll talk about in a sec. So of the 708 patients that we included, 209 received glucarpidase, 499 did not. Patients who received glucarpidase received it at a median of 54 hours from methotrexate initiation. And as you can see, 80% of the patients received it within the first 71 hours. These are some of the baseline characteristics. There were some imbalances. So those treated with glucarpidase tended to have more comorbidities. They had more hypertension, more diabetes. Sorry, I don't know why these rectangles got messed up here. Must be U.S. versus Canada PowerPoint. I don't know. The methotrexate in general. So this is, I guess the bottom is cut off there. It's supposed to show that nephrotoxic medications on the bottom. The glucarpidase treated patients received more nephrotoxic medications, or were more likely to receive them, 55% versus 40%. So all of these imbalances actually made the glucarpidase group sicker. And most importantly, the glucarpidase treated patients had higher 24-hour plasma methotrexate levels, shown on the left, and greater severity of AKI, shown on the right, compared to the control patients. So these imbalances, if anything, are going to bias us against glucarpidase, or they're going to make glucarpidase, they're going to make it look like glucarpidase is making patients do worse because they start out sicker. Higher methotrexate levels and worse severity of AKI. So I know this is a busy slide, but this is this and we're gonna go through every single number on here. No, this is essentially the flowchart for a sequential TTE So unlike an RCT where it just branches off into two or three things, here we evaluate patients for eligibility on any given day, and the key eligibility criteria. Again, we had our overall eligibility criteria. We excluded patients altogether if they were moribund, if they had end-stage kidney disease. But starting with the 708 who were eligible, we then evaluate them for eligibility on any given day. So the main eligibility criteria on day one were, did they have AKI? And if they had AKI, they were eligible, and then they either received glucarpidase or they did not receive glucarpidase. If they got glucarpidase, they're no longer eligible for a subsequent RCT, for a subsequent TTE, I should say. But if they were in the control group, they could be eligible. Sometimes people refer to this as cloning. We've essentially cloned the control patients. So the control patients, you can be a control patient one day and you can be a glucarpidase treated patient on another day. So that actually increases your statistical power. And the other nice thing about that is it allows you to adjust for confounders on the day of treatment assignment. And so what ends up happening is you end up essentially with 4 separate TTEs, right? One on each of the one on day 1, day 2, day 3, day 4. And then the final results are you pool all of this together. But the key is that if you're in the day 3 TTE, you are adjusting for confounders on day 3. Now, some confounders, like what type of cancer you have, obviously that's not going to change. But the key confounder here is creatinine. How severe was the AKI? So there we have daily lab values on these patients. We are adjusting for confounding on the day of treatment assignment. And what we found was that glucarpidase treated patients had higher odds of kidney recovery compared to patients not treated with glucarpidase, with an adjusted odds ratio of 2.7. And this was true across a number of sensitivity analyses, across a number of subgroups. And it was whether you do it as a binary outcome versus a time to event with adjusted Cox model, we found similar results. And it wasn't just kidney outcomes. The oncologists, if there are any in the audience, are also interested in neutropenia and transaminitis and other outcomes. And we found that that glucarpidase treated patients had decreased odds of neutropenia and transaminitis as well. Okay. One other onconephrology study. Let me just see how I'm doing on time. Okay. Maybe actually I want to leave time for questions. So maybe I'm going to skip past this. Other one is cisplatin associated AKI, which I'm going to skip past. But basically we published in JAMA Onc just a few weeks ago that IV magnesium seems to decrease the odds of cisplatin associated AKI. But I'm going to skip past that and I'm just going to go to babesiosis. Babesiosis is an emerging tick-borne illness caused by the intraerythrocytic parasite Babesia microti. Infection results in severe hemolysis, which is actually how I got interested in it. As I mentioned earlier on, a lot of my interest is in hemolysis and AKI. And in some cases can result in severe acute organ injury and death. And rates are rising. Now, there's not a lot of babesiosis in Canada, but I did look up just before this. There was a paper or two published on tick-borne illness in Canada, and I don't know what happened with in 2021 with rickettsiosis. But anyway, there is some babesia in Canada, but it's pretty rare. This is primarily a problem in Nantucket. Exactly, it's primarily a problem in the northeastern U.S. And where I live, Massachusetts, and actually throughout the Northeast, babesia infection rates have been rising. And I'm so glad you mentioned Nantucket. So that's the other reason why I got interested in babesia. So I come from a family of sailors, and every summer we'd sail up from New York up to Maine, sometimes all the way up to Canada. But we'd always spend time in Nantucket. It's a beautiful island, and I don't know if any of you saw the recent Netflix miniseries, The Perfect Couple. It takes place on Nantucket. One of the first cases of babesiosis in humans was published in the New England Journal in 1970. And then throughout the 1970s, there were more and more cases reported all from Nantucket. And it was known as Nantucket fever in the 1970s. And to this day, Nantucket remains the epicenter of babesia. There's more babesia per population in Nantucket than anywhere else in the country or the world, actually. So what have we learned about babesiosis since the 19 hi, no problem. So what have we learned about babesiosis since the 1970s? Well, the published literature has basically consisted of case reports and single center case series. Um, I mean, and so in many cases, they put the number of patients in the title of the paper, like severe babesiosis in Long Island, review of 34 cases and their complications. So it's very limited data. So we launched Stop Babesiosis. Um, we we launched the study about a year ago, again with no funding. We collected data on over 3,000 patients who were hospitalized with babesiosis. We didn't care about the outpatients; they generally do well. We wanted patients who were hospitalized. We collected these data from 84 hospitals across 24 medical centers across, that's supposed to say states, across 8 states, with over 100 collaborators and over 800 data elements per patient. And we looked at things like epidemiologic findings, like the incidence and mortality associated with acute organ injury. Um, but arguably, the most important thing that we did was a target trial emulation to examine the efficacy of red cell exchange transfusion. So remember, Babesia is an intraerythrocytic parasite. It infects your red blood cells. So other than antibiotics, if you're really sick from babesiosis, the only way to get it out of the body is to basically hook you up to a machine and do red cell exchange transfusion, like they do for sickle cell, where you're basically, the machine removes your red blood cells, and then simultaneously you're getting transfused massive amounts of red blood cells. So it's a big deal. You need a central line. Some hospitals, you have to be in the ICU for this. And there's no data. There's no data on whether it works or not. It works, but again, biochemically, it lowers your parasite number, but whether it works, whether it has any clinical benefit is highly controversial. So again, it's been used in severe cases, but there's really no data. And so we did this TTE. I won't go through all the eligibility criteria, but the key eligibility criteria were you had to have a high parasitemia load, or a moderately high parasitemia load with acute organ injury or severe hemolytic anemia. And things like if you're a Jehovah's Witness, obviously you're not going to be eligible for an RCT, therefore you're not eligible for this. Or if you're moribund, you wouldn't be eligible for an RCT, so you wouldn't be eligible here. And again, we used a sequential TTE design, just like we did for glucarpidase. We used inverse probability of treatment and waiting, and the primary outcome was in-hospital death or 30-day readmission. Here's the sequential TTE design, very similar to what I showed with glucarpidase, except here we did it over 7 days instead of 4 days. And as you can see here, most patients who get exchange transfused are getting it in the first few days of hospitalization. And the average, most patients, in terms of the number of packed red blood cells, patients are getting anywhere from 5 to 13 units of blood, basically their entire blood volume. And we found that exchange transfusion had a major beneficial effect on the primary outcome, adjusted odds of 0.22. And this was true across a number of sensitivity analyses, secondary outcomes as well. And if you do it as a time to event analysis, we also found a benefit. So let me just conclude, and then happy to answer any questions. Target trial methodology combined with a multi-center approach, combined with collecting detailed data, I've found that these 3 components are a very powerful tool to answer key questions across a number of specialties in medicine. And I hope you enjoyed it. And I want to thank a lot of people who helped me with a lot of this work. My mentee and friend and collaborator, Shruti Gupta, who led a lot of these projects, my biostatisticians, all my collaborators. This is my grant support, but actually none of this, all this work for the most part was unfunded. So thank you. Happy to take any questions. Oh, please.
Thank you so much. Sorry, I missed the first few minutes of your presentation. I was coming from clinic. Just thinking of the target trial emulation, it's really interesting. Obviously, you're making use of the existing data, and these are studies that are challenging to do RCTs in. I guess one of the confounders or confounding by indication, I would think, and obviously that's kind of something that you've already explained you're adjusting for, like in the creatinine example. Can you expand on that a little bit, just in terms of the limitations and what people should think about if they're designing such a study?
Yeah, great question. confounding is, of course, the Achilles heel of observational research. And that's why I emphasize throughout the talk the importance of collecting as detailed data as possible. And that's why almost pretty much all of these studies we collected data by manual chart review, because there was no other way to get the vital signs and every, I guess, the labs you can get in an automated way, but the SOFA score in the ICU, it's collecting data by manual chart review is very time consuming, but it was so important in terms of dealing with that, confounding. The other thing in terms of, confounding by indication, one of the reasons why it's so important doing this on a multi-center level, not just to increase, not only does it increase your sample size, but it helps with that natural experiment, because as you go to other centers, people practice medicine in different ways. And so you have more of that natural experiment as you expand to other hospitals.
Thank you very much. This is the type of studies we've been doing at McGill for a long time. We don't have such a nice TTE acronym, but it confirms a lot of what we've done. It's very interesting. You got the collaboration of all these people to do the chart review. I'd like to know a little bit how you approach that, especially with no funding. That's one question. But the other question is, we've used here a lot of administrative health data, given that we have a universal healthcare system and we have a lot of good administrative data, and then conducting similar, we call them comparative effectiveness study, treatment A versus B, taking advantage of the natural experiment of various practice pattern. And then, we always worry about confounding by indication. And one thing that we've used is evaluating how big of a confounder you would have to have in order to affect the effect size of the association. So, you look at two parameters and, for example, ejection fraction, how big of a difference between the two groups would it have to be in order to change the results? So I don't know if you've used some of that technology.
Sure, I'll answer the second question first, as say sometimes. So I think what you're referring to is sometimes known as the E-value. There was a paper published in JAMA by a statistician from my institution who first described this, the idea of quantifying the magnitude of an unknown confounder. How large would an unknown confounder have to be to change your results from being significant to non-significant? We have generally not done that unless reviewers ask for it. That we have one or two papers where they've asked for it, and it's easy enough to do. The problem, of course, is there's usually not a single unmeasured confounder. There's usually multiple, and so to talk about the magnitude of one unmeasured confounder, is arguably not all that relevant. That would be my answer to that question. The first question, I think, was how did we get so many collaborators? So we have developed a network of collaborators over the years that now know us and trust us. Initially we told everyone, look, we don't have any funding, but everyone who contributes meaningfully will be a co-author on every paper. Now, how do you have 400 people as co-authors? That was a little bit of a learning experience. But basically, with the COVID stuff, at least, for each paper we had a writing committee, which usually consisted of several dozen people, generally the PIs from each institution, so maybe 40 or 50 people. And then everyone else was, they were listed in the supplemental material, but their names still show up on PubMed. There's a separate category in PubMed, you may know, it's being used more and more. You see this for large RCTs sometimes. It's called a collaborator author. But if you search your name in PubMed, it still shows up. So you can still put it on your CV. Although it's hard to collect conflict of interest forms from 400 people. So, yeah.
So I have another question. Yes, it's nice that you have collection of very granular data, like potential confounding variables. But there's a limited number of variable per outcome you have to have, 10 per one. So how do you deal with that? I mean,
Yes, great question. So, people debate whether 10 to 1 or 5 to 1. But yes, you don't want to have overfitting, of course. Um, most of our studies, we had enough events that were able to conform to that 10 to 1 rule. We didn't have any for every 10 events. We only had one covariate in the model. The other way to deal with it is with inverse probability weighting, because there your final model only has basically two covariates: the treatment group and the weight. So that's another way that you can deal with overfitting.
Another way to kind of replicate trials and observational studies, instrumental variables, because it looks like you're only using IPP, but there's other ways to replicate trials with observational studies.
We haven't done anything with instrumental variables.
So this is actually from Dr. Lawler.
Oh, great.
Who stepped out. Superb talk, David. Do you think there is a role for connecting TTE designs with RCTs using Bayesian methods in order to improve inference? Could this reduce trial sizes?
Oh boy, I have not done anything with Bayesian analysis. I know that you Patrick have done great work with that with the remap cap stuff. I do think for sure there is a role for TTEs to inform the design of RCTs, but I can't comment on the Bayesian approach. Sorry.
Great talk, David. I have one question about the data collection, like that. It's manual data. I think you get a lot of information, but I think it's very time consuming.
Yeah.
And have you tried like something like use a structural query language or any like natural language model, like try to collect this data?
Yeah, great question. We have not used artificial intelligence or machine learning. Well, actually, we have one or two papers where we use machine learning to help analyze the data. But in terms of collecting the data, to your question, we have not. Part of the challenge, of course, is this is multi-center. So each center would have to get IRB approval, and they would have to be familiar with using that type of technology. So it's not something that we've done yet, but as the technology becomes easier to use and people become more comfortable with it, it's certainly something that we're thinking about.
Thank you for your talk. I was wondering how you approach the difference in sample size between treatment groups statistically, because from the figures it seemed like, oh, the treated group is 30 people while the placebo group is 300. So how did you approach those differences?
So it's not a problem statistically if the sample sizes are different between groups. You put it into a multivariable model, and you're looking at the effect of treatment versus no treatment. Obviously, in terms of maximizing efficiency, a 1-to-1 ratio is the most efficient. But you want to have sufficient number of patients that receive the treatment, of course. But there's no rule that says that the groups have to be similar in size.
So one last question from the chat from Dr. Morelli. Thank you so much. Great presentation. What are your thoughts about the use of digital twinning to enhance RCTs?
Digital twinning?
Yeah.
I'm not familiar with that. Digital twinning, I'm sorry.
So no thoughts.
No, sorry. Haven't heard that term.
Well, with that, I would like to thank you very much, Dr. Leaf, for that excellent talk. And thank you to everyone for attending our last session for the season. And we look forward to welcoming you again at our clinical trial rounds in September. Thank you.